The live stream test 1 2 3 testing 3 2 1. Testing 1 2 3 testing 3 2 1.
Good morning, everyone. The Finance Committee for April 22nd, 2021 will come to order. Thank you all for being here. Let me pull up my agenda and we will get to work. So the first order of business, are there any citizens wishing to address the committee, Mr. Mendenhall?
No, sir.
Okay, thank you for that. Next item is approval of the minutes from the March 25th meeting. Entertaining motion on that item.
Move for approval.
Second.
This is Dorothy, second.
Motion by Mr. Powell, second by Ms. DeBose. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, everyone. Item 4, CFO report. Ms. Clark.
Hello, good morning. I have a presentation that if we could go ahead and bring up the PowerPoint. While that's being done, I do want to just let you guys know this is a follow-up from a question that we had back in November of last year as we engaged GEP to kind of jumpstart some of the initiatives that we have going on in supply chain. And it's just a few slides, just one slide, the last slide, I hope becomes very familiar. I'll be bringing that back about once a quarter as we have updated numbers, but you can go ahead to the next slide. So as we look at our supply chain, we know that we wanted to move more towards an advanced state. And you can read through these, but you know, as you look down the page, we're working on policies and procedures and the effectiveness of those. And actually later in this committee meeting, we're going to be reviewing, Daphne and I will be presenting the updated purchasing policy, which moves us a little bit forward in this continuum. The green state is kind of where we were back in November when GEP was engaged to accelerate our ability to get to that advanced state. We're also looking at data and software and the accessibility and how we use that. That's the second row in this slide. And then, you know, working also on data-driven decision-making and the centralization of how those decisions are made and making sure that as an organization, we are all on the same page with same products and maximizing some of those savings in those contracts. Part of that is also tracking how we report out, and the people and training are imperative. You can see in the blue column next to bottom row, we have upgraded some of the skill sets through training, some pretty intensive training for folks who do RFPs and work through some of those more complex negotiations. And we'll also start to work with defined category manager positions. So we'll have subject matter experts in nursing and cardiology and surgery, as well as support functions. And then, of course, what you're going to see a little bit of today is some of the dashboard reporting that we're working on. And we all know whatever it is that you track, you really start to drive change. So are there any questions on kind of the advancement of these skills? Okay, on the next page.
Sharon, before you go on.
Yes, sir.
Sharon, when do you expect to hit that third column? What's your sort of mental deadline for that?
Well, a lot of it depends on hiring the right people and getting the right training in place. But our goal is to see us get very close to that within a year.
Okay, great.
Now, this slide is more about how do we pick which contracts we're going to look at. So when you see the next 8 or 10 on the following slide, how did they get ranked? How do we choose what we're going to be looking at? And a lot of this is already intuitive, but obviously potential savings is going to be driving the importance. We also consider, is this up for renewal anyway? We're going to have to issue the RFP. So should we start to accelerate that? And you can read down through some of the other internal factors as far as timing and how long it's going to take through the contracting process, as well as just some basic supply and demand. How readily available is it? How many competitors do we have? And kind of basic on how long does it take us to get it here? So those items that are more readily accessible, you can often negotiate much more aggressively. So the next page is what we call our savings tracker, and this is a very high level of what's happening. It's not all that's happening, but I think especially from the board participation, I did want to start to bring forward contracts that you've already seen, and these are ranked from projected annual savings from high to low. So, you know, one of our largest items of work was around our distributor and hiring Medline. And if we can start to funnel more products through that contract, we can actually start to reduce some of the administrative cost. And that could be close to $2.5 million worth of savings annually. So we just did that conversion a couple of weeks ago. You guys voted on it. Excuse me. You guys voted on it in December. So I think next quarter we'll be able to have another column here, and you're going to start to see some of the actual savings. And you can glance down through. I'm not going to cover each one of these. The third one down was covered with interpretation services. Laura Burnside presented that a few months back, and we'll start to see the actual savings of about almost $400,000 on interpretation services, because we were able to reduce the per minute price of that contract. So this is just a big picture, and this is really what GEP and their presence here has given us, some of those subject matter experts, and it allows us to, again, jumpstart some of these savings that might have taken us another year or two before we were able to see. But just in this short time period, we've already identified about $5 million worth of annual savings that we're going to be targeting. And then there is a second set of upcoming contracts that we'll also start to evaluate very soon.
That's pretty significant. I mean, you look at that far right column. I mean, that's really moving the needle on that.
It is, and this is a departmental effort. It is not just supply chain. You know, interpretation services in that example work very, very closely with us to try to negotiate the better price. Medline is a hospital-wide. It's impactful across almost every patient care area. So this, even though supply chain might be driving some of this, we have involvement from all of the operational departments and leaders.
It almost saves us enough money to pay for all the stuff that Mendenhall wants us to buy.
We're trying to keep up.
No kidding.
So I hope you find this helpful. If you do have any questions, I'll be happy to answer them now, or you can reach out to me at any time.
Any questions for Sharon?
That's great.
I'd just like to get a hard copy of the savings tracker.
We can definitely do this. This should be on your board portal,
Okay.
but I'll be happy to email it to you, Dr. Weber.
Okay, thank you.
You bet.
Okay. Any other items, Sharon, for this piece?
No, that's all my remarks.
Okay. If there are no other questions for Sharon, we'll move to item 5A, which is the consider acceptance of the March 2021. I can't say 2021 today. Unaudited financial report, and recognize Ms. Clark.
Thank you. So March was a very strong financial month for us. And a lot of that had to do with both our CMI, the acuity of our inpatients, as well as we picked up a lot of volume on the outpatient side. This was probably, compared to budget, the strongest outpatient month that we had so far in the 6 months of this year. So if you can go to the next slide, one more, thank you. So looking at the inpatients again, although we were close to 19% under our budget projection for admissions, you'll notice that those patient days are much closer. And those patient days is how long is one admission in the hospital. And on average, you can see that down on the length of stay graph, almost 6 days for every admission. And that's driven and supported by a case mix index on the bottom left on the acuity, which is about 11% above our projection and over last year. Next slide. Our emergency department and urgent care are both still under budget, although you can see, remember February, as you look at that blue graph on the trend, remember February was the ice storm, and a lot of our inpatient areas really dipped down given that week of challenge. So March is on the way up, both from a trend standpoint, even if you look back in January for the emergency department, and urgent cares remain fairly consistent throughout the year. Where we saw some great volumes is both in the primary care clinic visits as well as specialty care. Primary care was up 9% and our specialty clinic visits were up 33%. We are continuing to open up schedules both from a telehealth perspective as well as an in-person visit. Our primary care is running about 42% telehealth currently. Year to date, that telehealth is about at the same level. It's fairly consistent month to month. On the specialty side of things, our telehealth is about a third of those total visits. You can see that by the line bar at the top. So we have, again, consistently about 38% telehealth in specialty this year. On the next slide, you'll be able to see how our surgeries are looking. Inpatient surgeries were only about 3% under, but look at how they've increased month over month. So we had planned to have in our budget a step up in March through some of those surgeries. And our outpatient surgeries have recovered. Again, we had a couple of lower months in January and February with an increase in the COVID rate and as well as that ice storm. So you can see that our outpatient surgeries are over. I'm not sure why that graph looks the way it does. It should be a green box. It's a green box on my graph, but outpatient surgeries are actually favorable this month.
Hey, Sharon, can I ask you a question?
You bet.
First of all, would you guys mind rescaling the observation case graphic? Because we can't see the top of that and it's going to continue to get worse unless we rescale that.
We can absolutely do that, Trent.
I'm guessing that the obs cases are what, over 1,800?
They are right at 1,800. So you're seeing the top of that blue bar.
Okay.
They were actually 1,797 for the month. So you see it, but I can see what you're saying. It appears that legend is right over.
Yeah, and the reason I'm even asking is because when you look at the correlation between urgent care and emergency department visits and OBS cases, it's a lot more OBS cases than I would have guessed. Are those OBS cases being diverted from places other than ED and urgent care?
So it's a little bit more complex of an answer than that. We have made some operational changes and in the way, so observation cases kind of toggle between not the ED, but more inpatient versus observation. So you can have a patient that gets admitted for observation for dehydration or some type of a respiratory issue, and then they can go right into an inpatient bed. And in some other cases, you can admit them as an inpatient, and then the physician, based on the criteria of admission, they might flip back to an observation case. So I think we're focusing clinically on what is an observation case versus what is an inpatient admission.
Okay. They're both still coming through one or the other, urgent care or ED though, right?
Yeah, most of our admissions do come from our ED.
Okay. All right. That's good. And one question too back, and this is, we've talked about this before, and I'm not sure that there's a metric that actually gives us a good indicator, but as we look at things like our primary care clinic visits and specialty care clinic visits, it gives us a good picture of, the numerator in terms of total number of patients. What it doesn't necessarily give us is whether or not that is due to an increase in patient load or whether it's due to an increase in our access to service. If we have significant number of patients, doctors out or vacations or vacancies, I'm trying to determine whether or not there's some way we could look at a ratio between primary care and specialty clinic visits and our access, our availability. And I only ask that because it's kind of misleading to see a number go up in clinic visits if it only came up because we made more panels available. Are you see what I'm saying?
I do. And if you would let me work with maybe Joy Parker and her team to see what metric or presentation we can actually prepare and bring back to you guys as a finance committee, I'll commit to do that.
Okay, great. That'd be fine. I appreciate that.
You bet.
What exactly do you want to see, Trent?
Chuck, what I'm looking for is to be able to look at our clinic visits, not just from the standpoint of how many people showed up, but from the standpoint of whether or not we have adequate capacity to accommodate the number of people that are showing up. Because if I have a significant number of people that would have been there had I had the doctors available to treat them, then it would be a different perception than just knowing how many people showed up. The way it looks today, it presumes that every single person that showed up or every person that needed a clinic appointment in that month got it. And that's probably not the case because we used to measure third day to appointment and all those kind of metrics. And that was a particularly cumbersome metric, but to the extent that we're also trying to review this from a qualitative standpoint instead of just a quantitative standpoint to understand whether or not we are making access available to the total number of patients needing care. That's a little bit different picture than just how many people showed up.
I got you.
So you're looking for provider advocacy and utilization then?
Yes,
I know.
absolutely. Better put than I did.
Yes.
The other one, Sharon, is there an opportunity, because as we plan for the new hospital, on the observation case and all that stuff, is there an opportunity to look at that and say these are potential number of volume that may support transition care clinic or something like that?
Mm-hmm.
Yes, I think there's a lot of, there'll be a lot of work as we do look at new inpatient areas and the development of that. That will definitely be something of consideration.
Right, because
how we account for those.
I can see that account for something we can predict for transition care or maybe hospital in-home hospital type thing or whatever we want to call them for down the road for virtual care, so that we can only bring, at a certain level when we start looking at devices and all that stuff to monitor from home and move them to appropriate care if needed.
Yeah,
Thank you.
I agree.
Thank you. Okay, on the next slide, this is some of our mental health statistics. You can see that patient days were under our budget by about 6%, but they are trending upward. Our psych emergency visits have increased as well, about 12% over budget and slightly higher than January or February. On the top right, you can see the clinic visits, again, kind of same format as we look at for primary and specialty. They are about 15% over and 42% telehealth. And then, of course, our outside medical services ended up being just slightly above budget at 4%. And so that's red because it has a negative, it's cash out for us as we access those partners. Next page. On our financial metrics, you can see that our days cash on hand went up slightly in March. We did receive a large supplemental funding payment from the state, so we kind of see a blip periodically on that. The increases in the prior months are mainly due to the receipt of property tax payments because we get those very quickly from the county. Our net AR days have fallen to about 39 days. And our FTEs per adjusted patient day are slightly unfavorable compared to budget at 6.1, and that is a year-to-date number. So that's representative of the first 6 months of our fiscal year. Next slide. On the next slide, this is our connection enrollment, and we have been mentioning that there's been some auto re-enrollments during the COVID period for about the last 12 months. So we did quarterly extensions, and so now there have been some people that have gotten almost 4 extensions for another 12 months of eligibility. And it is time that we go back in and have them reapply. We typically would have done that kind of on a rolling quarter basis. And so we saw a large dip. We are still working with those patients to have them reapply. And we may see another slight decline in April, but then those will start to level off and become more normalized. Next slide. This is our payer mix slide. Does not change significantly month to month. And the next slide is going to be a summary of how we actually performed this month. Can we flip to the next slide? Thank you. So for March, bottom line income from operations was significantly higher than budget at $23 million. Most of that, if you look at the top half of the income statement, is all in net patient service revenue. Again, just as a reminder, as preparation during the budget back in last July, we strategically increased where we felt like our self-pay mix was going to be because of the pandemic, because of the economic impacts, and our payer mix has remained stable and favorable to that budget. So our payer mix is definitely the biggest component of that above budget performance. And we also received a large payment from HRSA, who kind of during the pandemic is providing Medicare rate for self-pay patients that are COVID positive. We did not expect those payments to continue. They get extended about 60 days at a time. And due to the complexity of those patients, we are grateful to have that payment, but it was not budgeted for. Also, if you remember at the first page of graphs, our CMI is significantly higher. And from an inpatient perspective, that case mix index and the severity of the patient directly impacts how much we collect. We did have about 1.1 million of savings from an operational expense. A lot of that is in purchase service. We had lower payments out for some of our connection and self-pay patients from a SNF standpoint, from a hospice standpoint, and those fluctuate month to month, just depending on required care. So year to date, we have an income from operations of 93.2 million compared to 60.3. Again, the majority of that is up in net patient revenue because of the conservative payer mix that we budgeted, as well as some of the additional funding, and combined with the acuity increase that we've experienced this year.
Excuse me.
On the next page, we introduced this to you guys last month. This is unbudgeted operating expenses. We have some life safety. We have some bond project expenses. And I just wanted to continue to summarize some of these items. So most of these you've seen. Some of this has been rearranged to move up to the top of the page, things that have board approval. The things at the bottom are things we know we are planning or may not require board approval.
This is Suzanne Barnes.
Yes. Oh, Suzanne, did you
Yes,
have a
ma'am.
question?
No, I'm sorry. I'm gonna unmute myself.
Okay. All right. So a lot of the board approval items at the bottom, it might be less than $500,000 when we look at individual contracts, and you may or may not see these in the future, but we know that they are large projects that were going to be above budget. A couple of new items, we have some IT operating expenses. David Mendenhall will be presenting 3 or 4 of these contracts at the latter part of the meeting. I believe that although they were not specifically budgeted for, he has found some savings in some other areas that he'll be able to cover those expenses. But all in all, we're still right at $18 million of operating expenses. And then the next slide is focused more on capital and our access to equipment. So we did, the one change here is we had identified 1.96 million of life safety and facilities updates. And Adam Lane is going to present to you later in the meeting on the agenda item F, how we're going to spend some of those dollars. So the 817,000 that he'll be talking about was included in that 1.96. And then at the bottom of the page, another contract that Adam will be presenting. It's actually asking for approval for some architectural funds for the redesign of the women's health expansion and renovation, 4.25. So just a summary, if y'all have any questions, I'll be happy to answer those. But the new things you will be hearing about before the end of the meeting.
So Sharon, when are you thinking you're going to sell your first tranche of bonds?
So that's a topic for discussion. You know, I really don't think that we are going to be ready to do so for probably until the end of the year. It might be the end of the calendar year at the earliest. as we start to spend monies that we will identify as bond related, I'll be bringing back to you at some point in the future a reimbursement resolution, which will allow us to spend money and then reimburse ourselves when that is issued. However, there's a sweet spot that we're trying to coordinate, because that resolution is only good for 18 to 24 months. And then I only have 24 months or so to spend the actual bond funds before we start to trigger some other calculations. So, you know, we'll be talking about those resolutions as the planning committee starts to solidify some of the bond projects and those actual expenses that will be able to be supported by the debt.
Okay, thank you.
You bet.
Trent, you asked the question I asked. You're in that world a lot, Trent. Do you think rates are going to move up more toward the end of the year?
You know, it's so, in you know this, Charlie, I mean, it's so apoplectic when you look at, you know, there was a slight decrease yesterday, and yet you look at the inflationary trends and you think, how can that's not sustainable. So I got to believe that we're going to see increases. And one of the reasons I asked this question is that, you know, we have to balance cost of issuance versus the amount of time that we have to spend the money.
Right.
And one of the things that we're going to have to get to pretty closely, which is what Adam's working on and which Broadus is putting together for us, is we're going to have to say, okay, these are going to be first. And this is when we start. Right. And how much we decide to issue against what we think is a reasonable construction schedule is a really big question. But I do think we're going to be likely in a rising interest rate environment over the next 24 months.
Yeah, I think your point's well made. I think Sharon's right on it. You know, we got rising construction costs moving against us right now. That's not a negative, it's just a reality. And then I think, you know, I was on the phone yesterday with the Fed. I mean, you know, I'm only an $800 million bank, but I've got $190 million in excess cash. All these banks are set and flush.
Yeah.
It's got to move back with these construction costs. I was in Austin Friday. We got 3 projects going down there. You think real estate's gone crazy here?
Yeah.
Check out the Austin market. I mean, yeah. So I agree with you, Trent. I think, you know, a few basis points doesn't sound like much on the kind of dollars we're going to borrow, but I think Sharon and the entire financial staff is doing a good job monitoring that when the time's right. But once we get it prioritized, I think we're going to need to spend the money, because I think our production costs are going to continue to increase. Yeah.
And we bring in Hilltop, who is our financial advisors, into these meetings. So as we get closer, I've already met with the some of the legal folks that we work with as well, and we'll be ready to do that when the time comes.
Yeah, the point's made, Sharon. I agree with you. I think y'all are doing the right thing. Get ready, and when and if we can do it, then we won't lose 6 months worrying about documentation, all that. So I think you're on the right course.
It's going to be fun. Yeah. So look forward to it.
Good opportunities.
It'll be fun.
If we can flip forward a couple of slides to the graphs for Acclaim. There we go. So Acclaim had a very busy month as well. They are impacted by the increase in some of those clinic visits, as you can see by the slide. They ended up being about 11% over budget for encounters. Year to date, they're about 25% ahead on encounters. So they've had a great period. I'm sorry, that was a telehealth number. They are 21% telehealth this month, and some services we purchase externally, and other most of our services are purchased here in Acclaim. So they had a good month, mainly because of those volumes. You can see that their operating revenue was positive, and they were able to have some expense savings kind of throughout their income statement to create that positive variance. Year to date, they're $5.5 million ahead of their budget plan. Next slide. And so this is kind of where you really need to, where I focus on a monthly basis. The year-to-date side for the hospital, Acclaim, adding in the activity of the foundation, $73.7 million for the year compared to a $35 million budget. I will say that we do have a lot of unbudgeted items that we know are going to flow through during the last half of this year. We also know that we've had some timing savings that have helped create some of that positive variance that I feel like we're going to start to catch up on during the year. So more time will tell. We've got a tremendous increase on the revenue side of things, and we're also working through some of the projections for budget 22 on supplemental funding as well as volume assumptions, and we'll bring more of those back to you as summer comes around. That is all of my prepared remarks, unless there are some questions that I can answer.
Any questions for Sharon? Okay. Thank you, Sharon. I'll consider a motion to accept the financial report as presented by Ms. Clark.
Move approval.
Motion by Mr. Nguyen. Do I hear a second?
Brent, second.
Second by Mr. Petty. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, everybody. Move on to item B. Ms. Clark, consider approval of the LDF 72 purchasing policy. Is this Daphne or is this you?
So I'm going to let Daphne, she has been instrumental in the revamping of this policy. There's a lot of updates, a lot of legal issues that we had to make sure were addressed. So I'm going to turn it over to Daphne, but either one of us can answer if there are any questions at the end.
Okay.
Thank you. Thank you and good morning. So as Sharon mentioned, we're actually seeking approval of the policy, which is shorter, and it just establishes the tone and overall philosophy for our purchasing practices. But as is typical, we also bring the procedure, and that does contain certain delegated authority from the board. So we wanted to make sure that we covered off the changes there because those were definitely more substantial. I'll start with the policy, and I did include just a summary sheet with the documents that were uploaded to your portal, just so that you could kind of see the category of changes. The policy, being brief, just included changes to the department names to match what we're currently calling those departments. We cleaned up language related to applicable law. We deleted some language that was in there that called out an exception to the policy, which there really is not an exception to that policy, which is, again, the philosophy. And we cleaned up information related to non-discrimination in contracting. So I will point out on the purchasing procedure, Sharon was talking earlier about the involvement of GEP and kind of looking at those practices and working with our purchasing team. And Tom has been working closely with me on this as well. There weren't a lot of legal changes that had to be made, which is a good thing. We definitely had some cleanup to do, clarification of language. So most of the red that you see is really around that general cleanup to some citations and references, and contemplating more involvement by the strategic sourcing and purchasing department, and also the benchmarking systems that we have in place. Broadening the description related to competitive bid to address all of our competitive solicitations, and general changes to define terms for clarification purposes. And then also based on questions that we get from the field related to the process, we saw opportunity to kind of really articulate that better. The more substantive changes that I did want to point out are that we added some more precise language and requirements for solicitations of professional and consulting services. So there's new sections related to, we refer to them as RFQPs, because we were already using RFQ to describe requests for quotes. So for requests for professional services, we created that defined term and really outlined that process, which is similar to the RFP process. And then the other more substantive change was that we added exemptions for some things that were already being captured in some broader exemptions, but to really articulate to people that these would be covered as well. And those included fleet purchases, new technology developed to replace, enhance, or expand incumbent technology under an existing contract, and non-exclusive contracts for physician preference implantable items where we have multiple manufacturer products that we're utilizing. So that, even though it looks very extensive, that covers the overall changes to the procedure. And I am happy to take any questions related to that.
Any questions for Ms. Walker? So as you know, the board tends to be weigh in more on the policy side, and seniors or the executive staff directs more of the procedure side, although we obviously have oversight of that as well. So I tend to focus more on the policy than I do the procedure, just because it's really not an area that I have expertise in. But so I'm pretty comfortable with this. Does anybody have any questions or concerns? Okay, not everybody at once now. Take one at a time. Okay, hearing none, then we'll move to I'll entertain a motion on item B to accept the new purchasing policy.
Move.
Second.
I think I heard a motion by Mr. Bose, a second by Mr. Powell. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Daphne. Appreciate that. We'll move to item C, approval of the second amendment to the administrative services agreement between Acclaim Physician Group and Tarrant County Hospital District. Ms. Clark.
So thank you. These next two agreements are actually intercompany agreements, and it allows the transfer and purchase of services between those two companies. Item C, these were both approved by the Acclaim Executive Committee earlier this month. Item C is what we call our administrative services agreement. It is the smaller of the two. And this allows Acclaim to pay JPS for certain services such as HR, payroll, accounts payable, IT, etc. And then going the other direction, there are physicians that are employed within Acclaim that serve as part of the administration, such as the CMO, the CMIO, and the Chief Quality Officer. So the net of those two is about $500,000. And we are looking for this approval. All of these intercompany transactions have been appropriately budgeted for in each one of the operating companies.
Okay, any questions for Sharon on this item C? You guys are easy today. So I entertain a motion on item C.
This is Zim, move to approve.
Motion by Mr. Zimmerman. Second by Mr. Wynn. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, Sharon. Item D.
So item D is the professional services agreement, and this is how the medical center will pay Acclaim for utilizing administrative time of many different physicians. There's kind of spelled out here. There are some subsidy agreements. There are a lot of medical director agreements. And that is at about $35.5 million a year.
All right, this is a big one. Any questions for Sharon? Okay, hearing none, I entertain a motion on item D. Sorry.
It is excluding sounds, right?
Correct. This does not include, did you say excluding sound physicians?
Right.
Correct. This does not include any of the contracted coverage groups such as anesthesia or the ED or in-house. This is actually clinical coverage from Acclaim employed physicians.
Thank you.
You bet.
Okay. Entertain a motion on item D.
Move approval.
This is Doe. I say move approval.
We have a motion by Mr. Nguyen, a second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Hearing none, motion passes. Thank you, Sharon. We'll move.
One quick question is
Yes, sir.
The service in here include hospital lists. So is that by mistake?
No, that's a terminology. The hospitalists are actually, I've asked them to change the name of that. There's 5 to 7 physicians who help do some training of the residents that are in-house, and they actually round on patients within JPS. So that is not representative of the sound group itself. That is external.
Okay, thank you.
Thank you for asking.
Okay, no further questions. We'll move on to the next item. Mr. Lane, item E.
Good morning, everyone. Great to see you all again. I hope everyone's doing well. I have 3 items today. The first one is for $4.25 million. It's for design fees, the design budget for the renovation of the Health Center for Women into the main campus outpatient medical home. I'm very excited about this. This is the second piece of our bond initiative in that this is for functional space programming and, again, a conversion to our first medical home within the bond program, and it sets the basis for our community health foray. So we have already gone through the RFQ process for an architect, and we are very excited to get this going. Again, this sets up the counterpart of the 2 visible components of community health. We've already discussed behavioral health in the last meeting, so this really gets the ball rolling for us.
Okay, any questions for Adam? Okay, hearing none, I'll take a motion, entertain a motion on item E.
Move approval.
Motion by Mr. Nguyen. Do I hear a second?
Steve, I'll help you in second. It's Chet.
Thank you, Dr. Schrader. A second by Dr. Schrader. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes.
Thank you.
All right. Item F.
Item F is part of our regulatory work for Joint Commission. This is for renovation of the ORs throughout the facility, specifically replacing the floors and the wall protection to get us within regulatory compliance for infection control. And this moves us well down the path to set us up for success when the inspection does come from Joint Commission.
Okay, any questions for Adam on this item? This is a really robust group this morning. Adam, you're just nailing it, man.
What renovations are they going to do and when are they going to do them? This is Ziegler.
There you go.
They are replacing all the floors and all the procedure rooms and all the ORs, as well as all the wall protection. Currently, the vinyl floors, the seams are coming apart in those floors. We're going back with stone hard flooring, and we're putting wall protection where Currently, the boom arms are swinging into the walls and damaging the walls. So, of course, those create infection control issues, and this will permanently fix those problems. And
but
should start shortly after the board approves this. We are looking for wall protection in the market right now because it's a special order.
How long is this going to take, and how many rooms will be down?
It looks like 2 at a time. We're working through Dr. Miller as well as Mrs. Saunders to schedule this, but we are trying to do 2 at a time on each side of the street. We're working through that process right now.
So let me comment a little bit on that. As you know, timing is going to be challenging because we're also transitioning anesthesia groups from Envision to Sound and trying to get everyone credentialed. We're following this very closely with Adam and Deb Saunders to make sure that Sound all gets credentialed because they're supposed to start June 1. There may be a few folks that may not get credentialed until June 11th. And then we'll time the schedule of the ORs, each OR, and obviously have to shift ORs during this time to change blocks and reduce some of the blocks while these 2 ORs at a time are going down. I think we need to move forward with this. I think doing 2 ORs at a time will decrease the time that we have the ORs down. So I suggest that rather than 1 OR. Adam, the one thing I'd like to know is how long the whole thing is going to take once it gets started.
To be determined. Once we get the final schedule of which ORs we can take down, we can get you that answer, but we don't have that yet.
Any other questions for Adam? Thank you for those, Dr. Ziegler. I'll entertain a motion on item F.
So moved.
Second.
Motion by Mr. Petty, a second by Mr. Powell. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you. Item G.
Item G is for approval of the contract with Premier Design Associates for master planning the MRI project, which was previously approved within the capital budget. It's for $535,000. We had 13 firms that responded to the RFQ. This firm is 100% minority owned, and they have been exceptional for us in the past, and I highly recommend that we use this firm.
Okay, any questions for Adam?
I heard highly recommend. I'd move for approval.
Motion by Mr. Powell, second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Adam. Appreciate that.
Thank you.
Item H, Ms. Dina Dent.
Good morning, everyone. Item H is for consideration for approval for a purchase agreement between OsteoMed and Tarrant County Hospital District. Just a reminder to the board, this is the overall vendor reduction from 6 to 4, and this is 3 out of 4. This will be a $281,974 cost annually, but the total vendor reduction will give us a $460,000 cost savings. This particular item will be a cost savings of $117,489.
Okay, any questions for Dina? Okay, entertain a motion on item, whatever that is, H.
This is Zim approve.
Motion by Mr. Zimmerman.
Second.
Second by Mr. Nguyen. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Dina.
Thank you.
Dr. Elliott, item I.
Hello, good morning, everyone. Thanks for having me here. Good morning. So I'm seeking approval of the Fourth Amendment to the Medical Education Affiliation Agreement that we have for emergency medicine services and education between IAS Physician Group and the Tarrant County Hospital District. This is a budgeted item This amendment is actually an extension to align with actually the PSA that was approved that will go through September 30th. And the new agreement will follow the PSA's renewal for October 1st. It does reflect an increase in dollars that were reflected from an increased complement of residents in emergency medicine. Those are grant-funded positions for the resident salary. So what this does is support our faculty and our program director and their teaching responsibilities in terms of the administrative and teaching tasks that they're required to do per our accreditation body, the ACGME. We have updated your executive summary to reflect that increase in resident complement. So the budgeted item that we are asking for in terms of cost is $830,408 to take us through the remainder of this agreement. Thank you.
Okay, any questions for Dr. Elliott?
I do. What is the balloon in the background?
I should probably blur it out. I don't know how to do that in this. This is actually in my office. My team surprised me with wonderful decorations for my birthday. So it's reflecting a milestone, which you can see.
looks like so. So it's.
Yeah, somebody said that, and I said maybe I'll just point and say so.
I thought it's a new 30.
Thank you, I love that.
Hey, Dr. Elliott, Trent Petty, happy birthday first.
Thank you so much.
The cost, would you say the cost on the contract again for me, please?
Sure. We updated with a new executive summary. The previous was $749. We had to update that, and we apologize for that, but we had to update that. It's $830,408, and that is budgeted.
Okay, so will we have to do a new agreement then this September with them?
Yes, we'll be seeking that just as we're going to seek a new PSA with that. This is just an extension to be able to get through the period of time. And so we'll align that with the PSA for both. We'll go forward and come again to this board for agreement, the PSA and the MEAA at that time.
Great. Thank you very much.
You're welcome.
Any other questions for Dr. Elliott?
Make a motion to approve, Steve.
Motion by Mr. Petty. Do I hear a second?
Second.
Second by is that Mr. Wynn?
Yes, sir.
All right, second by Mr. Wynn. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you.
I think
Steve.
I'm sorry.
Dr. Schrader may have to abstain.
Yeah, I wanted to make sure to just be documented as abstention.
Okay, please let the record reflect that Dr. Schrader is abstaining from that vote.
Thank you.
And one other thing, while we're on that issue, with the Acclaim agreements, should those of us that are Acclaim employees have abstained as well?
Yes, sir. That would probably be good, Dr. Ziegler, and we'll have the record reflect that when it comes to an Acclaim vote, unless you otherwise tell us differently, you will be abstaining from such votes.
Thank you.
Yes, sir.
Okay. Dr. Elliott, birthday girl, item J.
Thank you, Salsa. So we are going to go on to the next agreement here, which is similar in nature. It's seeking approval of the second amendment to the medical education agreement between Acclaim and the Tarrant County Hospital District. This also is an extension to align with the PSA, which will expire September 30th. So as I mentioned, we will go ahead and bring that forward with you with the PSA in the future. This increase actually does reflect an increase in resident complement in family medicine and psychiatry, which are all grant-funded positions, which we're happy to show. And also the ACGME has updated some program director requirements and dedicated teaching time that we need to reflect in these dollars. So we're seeking this approval. We have updated also the number there that is a budgeted number for $2,769,615, and it is included in the FY21 operational budget as mentioned. Seeking approval for this. Thank you.
Okay, you've heard Dr. Elliott. Any questions for her?
Just a clarification. What is transitional year?
Yeah, transitional year, that's one of our programs. It's an accredited part of ACGME. What happens is there are certain specialties that require their residents to go through 1 year, an internship year that really involves things where they're seeing different areas in terms of medicine. They see OB, emergency medicine, they rotate. So certain specialties do require that. One historically was ophthalmology, but now they have moved to more categorical, including their first year in their full training. But other programs such as dermatology, radiology, some anesthesiology too, some other programs require that first year. And so transitional year programs are across the country. And we've had ours for many, many, many years, led by Dr. Donald Nelms, a very successful program with very competitive applicants. And so that's what we do. We provide that 1 year training where they're interns with us in those specialty capacities.
Great. Any other questions for Tricia? All right, entertain a motion on item J.
I'll move to approve.
Who is that? I'm sorry.
That was
Dr. Schrader.
Oh, thank you, Chad. Motion by Dr. Schrader, second by
Zimmer, second.
by Mr. Zimmerman. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, Dr. Elliott.
Thank you.
All right, no other important business come before the committee. We'll move to item K. Dr. Mendenhall.
Dr. Mendenhall, I love that one, Steve.
That's what D stood for. Okay.
Yeah. And also, I appreciate that this committee has been so nice to everyone else leading up to these 7 contracts, which makes me very, very concerned on how the 7 contracts are going to go. So,
yeah, we're done with nice.
Yeah. Letter K, which is contract number 898-675. Let me first talk about in totality, there's 7 contracts. The first 2 work together. And I'll talk about them individually. The second 4 work together, even though we'll go through individually, and the 7th one stands on its own. But the first 2 are with the city of Fort Worth. The first one is the communications contract. One of the things that we're trying to do is update the communication systems that we have at the jail, specifically for all of the nurses that are out there, the pharmacists that are out there, all the people that are out there. We have tried pretty much every technology known to us, from ASCOM phones to cell phones to voice over IP phones and so on and so forth, and we just cannot get a decent communication system out there without riding on the city of Fort Worth's backbone. And so these 2 contracts are for us to purchase. We will be purchasing radios, but we need these 2 contracts to be able to do an interlocal agreement with the city of Fort Worth to be able to ride on their communications backbone. So the first contract, which is 898-675, is that communication system agreement between City of Fort Worth and Tarrant County, so we can begin that process of riding on their backbone for communications out at the jails.
Okay, so you've heard item K. Any questions for David?
Actually, I'm a little bit confused between the backbone communication and the P25 radio system. Are we talking about radio, or are we just talking about backbone for the infrastructure to carry the communication?
No, we're talking about the P25 radio system, right? So the city of Fort Worth has the P25 radio system that goes across all of the jails. Tarrant County uses the city of Fort Worth. We're going to be using the city of Fort Worth. And that's what, so when I was saying backbone, I apologize. I was saying the P25 radio system in very specific terms. So we will be using handheld radios just as they do in those jails.
Oh, okay, so they broadcast over AM or FM?
You got it. Yes.
And those are run by the city, or?
Yeah, the infrastructure is ran by the city. We will own the radios, and we will be connecting to their infrastructure to be able to go through all of those buildings.
See, will we be able to broadcast stuff like healthcare information?
So that is training that we're going to be able to do. We will have our own signal ID that it will be just our providers that will be speaking on that. And the only other people that would be able to tap into that or hear that are the people that are administrating those radios. Now, we could change to a different signal ID on the handhelds, which would then allow us to broadcast to other providers or other, like to the wardens or to the sheriffs that are managing those jails. That is obviously an opportunity for us to be able to do. And someone would then have to subscribe to our subscriber ID to then be able to listen to the healthcare information. So those types of things are things that we've been working through with Tarrant County as well as the city of Fort Worth to make sure that we're on a secure channel.
What I'm trying to get to is, are we talking about, station like safety concern for up-to-date news and, religious station? Are we talking about, because I'm concerned about, sometimes you put propaganda. I'm coming from a place where broadcast signal can be for propaganda stuff, and I'm a little bit concerned on that. So
yeah, no, these would only be used for safety of the employee, safety of the patient, something that most likely how we use ASCOM phones within the hospital, right? So we would be communicating things like this particular, duress signal, right, for a patient, for a nurse that might be with a patient, with an inmate at that particular point in time.
Oh, okay. Oh, you're talking about communication, like walkie-talkie type thing, not?
Yes, walkie-talkie type things. You got it.
Got it. Thank you.
Okay. Any other questions for David?
So move approval.
Motion by Mr. Nguyen. Do I hear a second?
Second.
Second by Mr. Bose. All in favor of the motion, say aye.
Aye.
Opposed? Motion passes. Thank you, everyone. Thank you, David. Item L.
And the second agreement, again, is as I was telling you, that it works hand in hand with the city of Fort Worth to make sure that, because there's two different interlocal agreements that the city of Fort Worth requires for us to be able to do that. So the second agreement, which is 898679, is that agreement.
Okay. Any questions for David?
Move approval, Trent.
Motion by Mr. Petty.
Zim second.
Second by Mr. Zimmerman. All in favor of the motion, please say aye.
Aye.
Motion passes. Thank you, David. Thank you, everyone. Where are we now? Item M.
Right. So this is contract number 902367. And these four contracts, are a bundle of contracts. We put them on four different line items because that's how we budgeted for them at the beginning of the year or last year when we budgeted them. I also want to speak to what Sharon identified earlier in the finance committee, and it was my oversight. I own this piece. When we put together these executive summaries, we said that the operating expenses was budgeted in the IT annual budget. And we did based on some offset, but in full transparency, when Sharon and I were preparing for this meeting, we wanted to be able to call that out, that even there wasn't specific line items for these, but they are being paid for by savings that we have in other areas. So I wanted to make that very clear as we move forward in transparency. So of the four, the first one that we're talking about is some change out of some infrastructure that we have had for about 6 years on our books. We are moving from a Cisco UCS platform for our hyperconverged infrastructure to a VMware VxRail hyperconverged infrastructure to get on some much faster processing for a lot of our storage and compute that we have within our data centers. So this is the first of these four contracts to be able to remove infrastructure that is about 6 to 7 years old.
So show of hands, anyone who knows what David just said.
I'll take that.
Even David didn't raise his hand. That's a little.
I'm so sorry. I'm so sorry.
Okay,
hopefully that wasn't how many people approve the contract.
I'm just looking for clarification at all. Any questions for David on this item?
How long do you think that will take for the migration?
The migration is the biggest thing right now, and I know you probably understand this, Mr. Nguyen, is getting the product in, right? The ship time for this particular product is about 90 days. And then once we get it in, we're hoping to be able to rack and stack these components within 30 days and transition within 30 days. So if the faster we get it in, I'm expecting a 30 to 60 day time period to be able to migrate over.
Any contingency plan that you may need from moving from the legacy infrastructure to this new one?
The contingency plan is we move things to our other data centers, right? And so we already have pilot pieces of equipment already in one of our data centers so that we could move over to one of those other data centers to be able to move it, which is when we did our proof of concept and did, for lack of a better phrase, we did a bake-off between VxRail and Cisco UCS. We have that proof of concept gear of VxRail still sitting in one of our data centers that we can move over to if there was a failure with our current infrastructure.
And this one increase the processing power by.
We're looking at a 4x processing power increase. And not only the 4 times processing power increase, because we're using hyperconverged infrastructure, the boot times are significantly faster, the compute time is significantly faster, the memory that we can do things on board right there locally on that server is significantly faster. So 4x is just a minimum.
No need for caching, I think.
All the caching will be done locally. Right before we had, and actually the fourth contract is for a new storage area network. But because we can do most of the caching locally, we don't have to move it to the SAN, which is going to, again, increase performance.
Working yourself out of a job.
That's okay. That's okay. As Robert and Sharon tell me all the time, I'm in the weeds too much and I need to sleep. So the more I can sleep, I think the better off all of us are going to be.
DT, was that a motion?
Yes, sir. Motion.
Second.
We have a motion and a second on item N. Thank you, Mr. Petty. So I want a hyper-converged infrastructure vote on item M. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Mr. Mendenhall. Item N.
So second hyper-converged infrastructure change out is on contract 902370. The first one was for our basic file server, compute application servers. This is for our SQL environment, our database servers, all of our reporting servers that we pull data from Epic and be able to serve that data back up to Reporting Workbench, to Power BI, to all of the things that we use for dashboarding across the organization. This is for our reporting systems, same platform for hyperconverged infrastructure.
You had us at hello, Dr. Mendenhall. Motion to approve.
We have a motion by Mr. Petty, a second by Mr. Bose. Any questions for David on item N? Hearing none. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, David. Thank you, everyone. Item O.
Last one on hyperconverged, and this is the VDI, our virtual desktop infrastructure, our tap and go that we use in the ER that we're going to be moving out to community health in this next phase. We also have it in the tower, so it's a swap out of that infrastructure for VDI phase 3.
Okay, any questions for David? Hearing none, I'll entertain a motion on item O.
Motion for approval.
Motion by Mr. Wynn, second by Mr. Bose. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Thank you, everyone. Thank you, David. Item P.
So last one, contract 902416, is the final of these 4, swapping out old infrastructure. If you remember, about 5+ years ago, I came to the board and increased our storage area network using Hitachi Data Systems, HDS. HDS is really no longer a competitor in this space. And you've seen me over the course of the last couple of years start purchasing products from a company called NetApp. And NetApp is one of the storage leaders for these types of arrays. And so this is now moving our production Epic in 2 different data centers and removing all of that HDS, all that Hitachi Data Systems gear to be able to get off of it. One of the things that that is included in this pricing is about an over $200,000 discount to actually take the old gear as kind of a trade-in, if you will. And there's really no street value to it, but NetApp decided to do that to be able to sweeten this particular deal. So there's about I think it's $12,000 or $16,000 trade-in on this as well.
Okay, I heard David. Any questions for him on item P? David, I would just caution you to, when you use the term swapping out old infrastructure, that makes Robert kind of nervous. So don't use that too much. With no questions, I'll entertain a motion on item P. Motion by Mr. Nguyen.
Zim, second.
Mr. Zimmerman seconds. All in favor of that motion, please say aye.
Aye.
Opposed? Motion passes. Thank you. Item Q, Mr. Minnick.
Yeah, I just hope Robert doesn't decide to swap out his CTO anytime soon. So
no guarantees.
I know.
I feel really good, David, about my CTO, my cash, and my sand. I'm really pleased about all of them, actually.
Unfortunately, you and I spell cash differently. C-S-H versus C-H-C-H-E, but that's okay. The final proposal in front of you and contract in front of you is with an organization called WWT. WWT is a minority-owned business that we have started doing a lot of business with for infrastructure purchases over the last 6 to 12 months. We're very excited to be able to bring this to you guys. This is actually a refresh of our wireless network throughout the organization. Our current wireless network is about 7.5 to 8 years old. We did a significant trial between Cisco Wireless and Aruba, and we chose Aruba. What's really interesting of why we chose Aruba, why I wanted to bring it up to you guys, is WWT is actually the biggest Cisco vendor in the world. So for them to come in and be able to do a proof of concept with us with two different vendors and go away from their core competency of Cisco and say, look, Aruba would be a better fit for JPS, was a lot of the things that we have going. Very confident in this particular purchase. So that I put that in front of you for your consideration.
This one I almost understand. Thank you, David. Anyone have a question for David on item Q?
Is this for wireless for data usage or is it for voice?
It's actually it's not for what you would consider like cell services. This is for data, right? But we run a significant amount of voice over our data network. And over the course of the next couple of years, we're going to be running the majority of our voice traffic that is local here to JPS over that data network.
This is for voice over IP.
Yeah, for wireless voice over IP. You got it.
I assume that you already review all the cybersecurity network security.
Yeah, so what's really interesting on this particular thing is we're able to run 802.11ac and the AX platforms, which has built-in encryption point-to-point. So by doing that, we offload a lot of those things. And on top of that, any application that we would do would have those encryption protocols built in as well.
It's the key change.
I didn't quite get that, DT.
Or the encryption key is being changed all the time.
The encryption keys on our wireless network, even today through the radius, is changing every 60 seconds. So with that, we're able to continue moving those channels as fast as we can.
Thank you. Move for approval.
Motion by Mr. Nguyen, second by Mr. Bose. All in favor of the motion, please say aye.
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 Opposed? Motion passes. Thank you, David, for all of that. Thank you, everyone. I've been informed we have no items in executive session. Is that correct, Ms. Walker? Just to confirm?
That is correct. Thank you.
Thank you. All right. With no other business to come before the committee, we are adjourned. Thank you, everyone.
Thank you.
Good afternoon, everybody, and welcome to the April 22nd meeting of the Governance Committee for John Peter Smith Hospital. We are here via Zoom and hopefully to resume in-person meetings quickly. I will call the meeting to order at 12:02 and will ask if there's any citizens wishing to address the committee. Nobody is waving or flagging me down, indicating that there is.
You're good.
We do not have any, Mr. Chairman.
Thank you, sir. So no citizens wishing to address the committee. I'll move for an approval of the minutes for our February 25th meeting.
This is Zim approve.
Thank you, Zim.
Dorothy, second.
Zim with the motion and Ms. Dorothy with the second. I'll ask for any dissent and we'll vote that way, assuming everybody else is the affirmative. Are there any dissenting votes? Hearing none, the motion passes. Hi, Dorothy. I thought you weren't going to be here today, so it's good to hear you at least. I can't see you, but good to hear you. And so committee chair report. I don't have much to say other than, I'm continually happily surprised every time that I visit a JPS facility. I had the occasion yesterday to get my COVID vaccine and from the Northeast Clinic. And let me tell you, it was a busy place and it was a well-organized and well-oiled machine with happy people all around. Robert Early told me to bring my blankie to comfort me if I needed any comfort. And I gladly left with a lollipop. So I appreciate everybody at the Northeast Clinic, as well as all of our providers, doctors, nurses, frontline staff, everybody down to the people in the lunchroom and the people in housekeeping. This has been a long year, and it is very refreshing, certainly now after having the shot, that we might be seeing the light at the end of the tunnel. So thank you all for your continued efforts and keeping all of us well and safe. That's all I have as far report. I will go now to item 5, considering governance committee reports, updates for discussion and/or committee action. And real quick, I do want to say, I have one other thing. I want to thank, number one, all of the team in enterprise risk management, internal audit. With a little bit of turnover here, they've done a tremendous job, keeping the boat on course. And I want to thank Daphne Walker for serving in an interim role as the chief of compliance as we work to fill the position. It's been great. I had my walkthrough with him last week and very happy with it and very happy with the job everyone's doing. So for a very small team of people, they do a heck of a lot of work. I'm really proud of. So item 5, we have a enterprise risk management update. Arena, are you on?
Yes, I'm here.
Good to see you.
Hi, thank you. Hi, everybody. I would like to give you an update on the My Texas Direct Workers Compensation Program. If we can go to the next slide. And this program was implemented in January of 2019, and it is a 504 multi-member network that offers more efficient medical care for our injured employees. This was accomplished by providing injured employees with quicker access to providers and specialists at a variety of locations. The efficient treatment resulted in a reduced number and cost of medical bills. And so another benefit of the program as well is that providers are also following a standardized set of guidelines for return to work, including modified duty. And this led to a resulting reduced number of employee lost days. So the savings below actually includes a total of medical and indemnity expenses. And as you can see, there was a savings at $43,000 at 6 months, $239,000 at 15 months, and $454,000 at 24 months. And so the program is due for renewal in January, and the employees have seemed quite pleased with the program as well. And I just wanted to make sure we had an update since it had been 2 years since it was implemented.
So Miranda, these are savings that the hospitals experience. These aren't savings that have been passed on to employers who send their employees through the network.
Yes, it's for the hospital expenses. Yes.
Is there any way you can give us a picture of how many, I guess, claimants, so maybe the right word for it, and how many people are we looking at, and what is the main thing that they do that really impact these numbers so that we can get some learning experience, because as we go through population health,
yeah,
we may be looking at some of these impacts also as well.
Yes, we can also share that as well. But to get these numbers, you look at from the time of treatment to the time that they are released. And we can definitely provide those details of what those claims look like. But by seeing a provider sooner, that means that somebody's not sitting with an injury longer to where they will need more care. And with this program, we're able to avoid pre-authorizations because most times it's a sprain or a fall, and usually all they need is physical therapy, and those pre-authorization bills add up. And so that helped contribute to the cost as well, the savings.
Is that better network management, or is that, and how many people are we looking at? Do you have any idea?
Yes, as far as the total number of claims that we're looking at, it varies over the different time points that we've had. But it's a couple hundred claims that we're looking at through the years. Through these past
Sounds like you want us to bring back some more precise information related to the number of claims that this encompasses and what's really driving those savings. Is that what I'm hearing, DT? Because we can bring that back for sure.
Yeah, because we don't know if are we dealing with 50 people, 100 people?
Yeah.
We deal with 200 last year, only 50 this year because of COVID. Nobody's working. So just want to see what's the real. Is it apple to apple comparison? Because if people are not working, we don't have a lot of injury. That doesn't mean our numbers going to go down. Then we can see what's the impact of how much are we really impacting, and is it are they anything, what is it going to be through? Because depends on sprain and all that stuff. But if it's truly MSK, musculoskeletal problem,
yes,
and if they don't see because of COVID, they don't have access. That doesn't mean the disease progression is not going to be there for next year and all that stuff. So I have no way of.
So DT, number of claims and number of claimants.
Yes. And,
okay, we can bring that back to you.
And maybe be careful with HIPAA, because I don't know if we're going to trip over the HIPAA things here. But
we can give you overall totals as far as numbers.
And severity and all that stuff.
Sure, we can share that with you.
Okay.
And that would be over the 2-year period, correct?
Yeah.
Yes, probably better for us to see.
Yeah.
Okay.
I think it would be better over the 2-year. That would be able to see total number of claimant, unduplicated, and then you'd be able to identify what are your primary diagnoses, and then it'll be aggregate, so it shouldn't get into the HIPAA. Okay.
Right, because if the age of the claimant is, let's say, 65, and you roll with the 64 and roll with the 65, you do a set aside, and then Medicare picks that up. That doesn't mean that we actually reduce anything. It just we got lucky. Somebody just passed that age.
Okay.
Okay, we'll share that with you.
Okay, thank you.
Anybody have any other questions, Ms. Raina?
Nope.
Raina, do you have anything else for us?
No, that's all. Thank you.
Okay. All right. We will go to compliance program reports and updates. Michelle, I only see 5 people, so I'm assuming you're out there somewhere in Neverland.
I hope so. Can you hear me?
There you are. I hear you.
Okay. Excellent. So thank you. So for open session today for compliance, we wanted to again provide snippets for board training like we typically do. And then, so it's all going to be on conflict of interest today. And then we're going to provide a semi-annual update of our 21 work plan for compliance. So on the first slide, I think what I first failed to do on this one was really define what a conflict of interest is. So in essence, it's any financial or non-monetary interest that would interfere or be perceived to interfere with what is in the best interest of JPS or its patients. And I know the board has a policy and procedures called LD 1100. That's a very detailed, it's like 9-page policy that describes the requirement for conflict of interest disclosures upon appointment as a board member. It requires them annually, and it also requires them anytime thereafter where there might be a change in your circumstances that could result in a conflict of interest. So this year, compliance is completely covering, fully responsible for gathering and analyzing all of those conflicts of interest questionnaires, statements, and disclosures. And what I wanted to introduce you to today is our process of doing that. So what we are going to do is send out, and part of your ebook should have been a 1-page PDF attachment that would describe how we're going to do this electronically. Instead of the 8-page manual form you were filling out in the past for general counsel, we are going to do it electronically. You'll be receiving an email later this afternoon, sometime after 4 to 5 p.m. And we're going to ask that those disclosures be completed by May the 15th. So first we would disclose, I know it says here that one of the reasons we put here hundreds of vendors. So your relationships with vendors are very important. And I think what we should have said there was thousands of vendors, because I did a little research yesterday and learned that we paid about 2,600 unique vendors in the last couple of years, just in the last 2-year period. So it's a lot to keep up with. What we do is we receive those, we're going to review those conflicts of interest disclosures within compliance. We have a designated person to do that. She is an attorney, and she works closely with general counsel. So Daphne's office, she's going to work with anything that might require some interpretation, maybe some language around putting together some sort of action plan to monitor that conflict of interest. And again, that'll be done in concert with general counsel. The other thing I wanted to say is the email that we're going to send this out to is going to be the email that you use to receive, or we use to send out those ebooks. So as long as that is a good email and everyone's receiving the ebooks, that is the email in which we will follow through with those today. Okay, next slide. This is just a little bit of dive into the requirements that are listed in your LD 1100 policy. So the Texas Local Government Code is referenced in there, Chapter 171, which requires you to file and abstain from voting, file an affidavit and abstain from voting if you're required to do that. Listed below are the reasons in which you'd be required to do that. So if you have a substantial interest in any business or real property, then you'd be required to abstain and file that affidavit. Again, general counsel would be responsible for holding those affidavits. Substantial interest below is defined as ownership of 10% or more of voting stock or shares in a business entity. Ownership of either 10% or more or $15,000 or more of fair market value of that business entity. Receipt of funds from a business entity that exceeds 10% of a person's gross income for the previous year. And then as it relates to real property, it would be equitable or legal ownership in real property with a fair market value of $2,500 or more. Again, this is nothing new. It is in your 1100. Next slide, please. So these are just some questions critical questions I think that we put together to consider so that you could avoid the appearance of a conflict of interest. So again, can you exercise independent and disinterested judgment? So do you have a competing personal or professional interest? In other words, or does your relationship with a business appear to conflict with JPS goals? Can you gain or lose anything of value? That's an important question to ask when deciding whether or not to do business with a particular vendor. And then will your participation induce or reward patient referrals to JPS? So again, any one of those things could potentially be perceived as a conflict of interest. Not all disclosures, again, will result in a true conflict, but they just need to be evaluated. At the very bottom is a how to get in contact with us. So again, the one-page handout does have some FAQs, and it does describe how to log in to the COI system to answer those questionnaires. What you'll find this year that's different, it's not just one blanket question. There will be a follow-on series of questions to help describe the matter. So it doesn't require a lot of reaching back out to you and determining what are your interests. If you would prefer, of course, you can contact us to walk through that. Again, at 23728, or you can email compliance@jpshealth.org and someone will get back with you on that. One of the things the email will contain is it will have the URL when you receive it this afternoon. Your login will be your badge ID. So if you don't know your badge ID, that's okay. It should be in that email. So all you have to do is click it, and then you're able to establish a password and log in and complete the disclosure. Once again, those are due on May the 15th, if you please. And do I have any other questions regarding the conflict of interest disclosure process this year?
No, and the link will be part of that email for us.
I'm sorry, DT?
The link will be part of the email for us to link
Yes,
to.
sir.
Okay.
URL will be, it's probably the best way to do it is that URL in the email.
Thanks.
Okay.
Well, I appreciate y'all making this a simple form, and I'm glad to see that we'll finally be electronic after all these years. I did speak with everybody for the board members out there when we had our pre-meeting about this topic, that there may or may not be public humiliation on May 13th at our board meeting if these items aren't turned in. So you might receive a call from me prior to that meeting, just as a friendly reminder, because this is an important step of our board duties, as well as written in our standard operating procedures and bylaws. So it's something that we really need to do. And Michelle and the team there have promised all the help necessary navigating this new electronic document format that we're going to use.
Yep. Okay. Next slide, please. Our mid-year compliance work plan. Again, these 5 projects at the very top, these compliance projects, are the only detailed work plans that required a report back to you as a board. So it wasn't as if it's the complete compliance work plan. So we have the 340B, the privacy and compliance program requirements work plans, conflicts of interest being one of those compliance requirements. So again, what I put before you today are the 5 that require a report that are coming back to you. So you'll see that we are essentially, I think overall what my message today was that we're on schedule and the sky is not yet falling since Ron Skillins left. So we're good. We're still ready to produce the reports as necessary. Now, the one at the bottom, the emergency preparedness, I did want to say that one is on our radar, but emergency preparedness plans need to be reviewed and updated every 2 years. And there has already been a consultant in here to do that and to go through each TJC standard. And as you know, we're in the window of TJC anyway. So more to come on that one in terms of what the real deliverable is going to be on that. At the bottom section, there are 12 compliance monitors. And these are called sometimes what we call the first line of defense, the combined assurance model, or the operational compliance, again, compliance monitors that are actually done at the team level, management level. And it's not as if these are new compliance monitors. This is just us formalizing a process to get the management or the first line of defense to send us reports on the measuring of compliance of these areas. So these are essentially 12 new, more robust reporting of these 12 functional areas for compliance. So MOON being in, observation status of 24 hours, you've got to have a MOON form delivered. Advanced beneficiary notice, that's an outpatient non-covered procedures. Some of this requires 60-day notices, Medicare secondary payer questionnaires. Those things need to be turned in. So all of these things are really critical to regulatory compliance. And I'm really happy to report that they are on track, and they were part of the higher risk areas that we wanted to get established through our compliance subcommittee. Any questions? And I think if not, that would conclude the open session for compliance.
Actually, I have one, Michelle. On the BAA, is it underway? What are you guys looking for? Are you looking to make sure that they have BAA on file when they do business with us, or are they looking at the expiration? Or do we have a tracking system to alert us ahead of time to get the BAA?
We are looking to determine, first of all, can we produce a list of business associates? That's first and foremost. And can we produce it timely and determine what those business associates do for us? So as you might recall, we did report on this, I believe, about a year ago. So what that is a follow-up review to make sure that we are in a position to be able to do that. So one report, who are our business associates? The system to determine, I think I heard you say expiring of those, that's fairly automated through our UCM. So that's 6 months, 3 months. There's a lot of notices that come out when those are about to expire. So that's fairly controlled. It's just really following through with what we reported originally on, can we produce an accurate list? And do we have them for everyone that we should have them for? Does that answer your question?
Yes and no.
Did I hear it right?
Should that be controlled and have ready by when Neil was a general counsel? In that
DT, I couldn't understand your question.
Is that something that Neil firm control and keep track of, or is that something that compliance is keeping track of?
So that's actually a contract administration function that has, I believe now reports up through Daphne, General Counsel. Mm-hmm. And but I believe that when Neil was General Counsel, it really still reported through contract administration internally at JPS. And that has had different leaders.
And just to piggyback on that, it really crosses a lot of different functions, because there's one, how do we identify when we actually need a BAA in place, right? So there's a decision tree on the front end. Sometimes that's coming in because we're doing an IT process where vendors may have access to information or touch on our systems. Sometimes it's just because there's some contractual arrangement that contemplates that a vendor may have access to PHI. And so, figuring out how to make sure that people who are entering into those arrangements or interfacing that way understand when a BAA is contemplated, making sure that they go to the right channels to get one in place, and then make sure that it's trackable from a listing perspective. And I think that is where Audit did identify some opportunity, because sometimes you'll have a BA that's just an exhibit to an agreement. So when you go to search for those in the system, you're not going to readily identify them, right? Because they're part of that contract. And so then now making sure we have a separate category that's identified in the UCM that's going to make those contracts available for us to see, and also determine who we have business associate agreements with. And then the second piece, Michelle, I don't think you touched on this because I know you guys did make some comments to the policy. You know, we're auditing from a policy perspective as well to make sure that the organization is following our policies around entering into those arrangements.
Is it possible to structure in a way that, you know, there's different tier? Tier 1 has a lot of, like, for example, a lot of patient information, confidential information, whatever that is tier 1, so that if we need to pick and choose what we should be looking at first, get that out of the way so that we can go to the bottom tier later on, because even if you expose, you're not really hurting as much as the top tier from a compliance and from a CMS regulation and all that stuff. Does that make sense?
I didn't understand it, DT.
I was trying to see if we can break the tier as we monitor these into, you know, multiple tiers. Tier 1 is anything that patient related, HIPAA and all that stuff. So vendor that fit into that category, we constantly monitor to make sure, because any violation of that can result in a lot of penalty, civil and criminal. But, you know, the bottom tier is not as critical. It needs to be done from a compliance perspective, but less exposure for us, so that we can isolate the incidents and isolate the risk from the enterprise perspective.
Sure, and I think I understand your question. And Michelle, I'm not sure whether we have that tiered out from an audit perspective. So we could definitely take that offline and make sure that we are capturing those higher risk items first from an audit perspective and reporting on those. I think that's what I hear you saying, and
Right.
making sure that we're not focusing on the less urgent items as a priority.
Right, one's compliant, one is less exposure on the risk side.
So the significance of the contract or the business associate agreement is what you're saying. The significance or the monetary value is, you know, it would really be housed in the UCM and how we structure that UCM to really be able to pull out. But I think that UCM is very customizable. Absolutely. So there should be, it shouldn't be, it would be a challenge to go back to do something that we hadn't had practice of doing before. But going forward, I'm sure it's customizable enough to be able to do that.
Yes, well, yeah, the reason I'm bringing that up to tier that, because, you know, the exposure is one thing, and then we can also audit our vendor to make sure that they have appropriate coverage and all that stuff. Like if it's patient financial, do they have enough coverage if there's a breach there and stuff like that? Whereas, you know, somebody entering the building to change light bulbs, yes, there's a certain risk if they see patient file, but more likely they don't even know what that is anyway. So the risk is not as much as vendor that deals with patient information and treatment information and all that stuff. So
sure.
And on the you know, the legal side of that, you know, we start with uncapped. You know, if they're accessing any of that information, you know, we're not trying to limit based on risk. So we start with uncapped liability from a business associate perspective, and then, you know, they will try to limit their liability. And so those do pass through the legal team to review too, but there's definitely something we can do from an audit perspective to make sure that, you know, we're tracking those from a, you know, higher risk perspective.
okay. All right, thank you.
But I have a question for you, Daphne and Michelle. Can you hear me?
Yes, sir.
Do we have this tier mechanism set up already, or is this we gonna have to devise it, or you devise it?
Honestly, I can't answer the question because that review's still underway and it's not something I've had laid eyes on in a while. So we have one person assigned to that project at the moment, and I can't recall where we are on that. So it would definitely be in the UCM if we had it. I also, when you talk about tier vendors, though, as opposed to, contracts and things like that, I do know that certainly IT has tiered their vendors, all of our vendors, actually, from a security risk standpoint. So they have tier 1 vendors, obviously, for, business continuity and disaster recovery things. So in that respect, or in that regard, we have them tiered. But with regard to business associates, I can't say that we do. But it's something, as we follow through with this engagement, I will make sure that it's a consideration as we move through the project.
Okay, great.
I've made a note of it too, Dr. Weber. So as we continue on between Dabney and Michelle, and then once we get the review done, we'll figure out the best way to go forward.
Okay, thanks, Roger.
All right, we got Tim. Are you out there in Neverland?
I'm here.
All right.
Good afternoon, everyone. Next slide, please. All right, so similar to what Michelle just presented as far as her mid-year update on the compliance side, we also wanted to share with you our mid-year update on the internal audit side to let you know our progress to date on our FY21 work plan. So I'll point out a couple of things on this snapshot that you see here. You can see at the top the 2 completed audits to date, one of which around provider credentialing you're going to hear a little bit more about later when we present that audit to you. We're currently in the process of wrapping up an audit around physician payments and specifically directorship and on-call payments. We are completed with the field work there and in the reporting phase now, hoping to get that report out within the next couple of weeks. And then at the same time, we just started on a supply chain audit specifically around central supply operations. So that's what we're gearing up for next. And then down below, you'll see the remaining audits that have not yet been started from the plan. For cybersecurity in particular, you'll notice off to the side that we're proposing to defer that project to FY22, so either later this year or possibly early next year. And the reason for that is because we've had a lot of external risk and IT security consultants in the space performing cyber assessments over the last year. And in fact, one of these consulting groups that focuses strictly on healthcare cybersecurity just recently completed their assessment and is in the process right now of issuing their report to IT management. So we really wanted to make sure that the IT security team has time to digest and address whatever corrective actions come out of these external reviews before we then come in and do the internal audit, where you may remember we were also planning to use some of our cybersecurity experts from one of our co-source partners as well.
If we were going to do that, will BKD or somebody will ding us for that when they do the audit?
You're asking DT if BKD will ding us when they're doing their financial audit if we defer this project to FY22?
Yes.
Not to my knowledge, unless Michelle or anyone else thinks otherwise. But no, I do not believe that would be a ding against us in their financial audit.
Actually, Tim, this is David. I can speak directly to that. So we are able to give to BKD every year the internal assessments that we do. We pay third-party providers to do multiple assessments against us throughout the year. We provide those to BKD, and that suffices for this. This particular cybersecurity thing is following up to make sure we've done all the things that we said we were going to do, any remediations, any fixes, anything that's beyond that. But so this starting in FY22 is absolutely okay. It's a follow-up to make sure we've done all of the things in those corrective action plans that we said we were going to do.
And our cybersecurity insurance will be okay with that if we don't have that audit?
Yes, because again, we do 3 assessments annually, and those assessments by outside firms stand And those actually assessments are turned in to the cybersecurity insurance companies as they are completed.
Okay, as far as they okay, we should be okay too.
And one other thing I wanted to share with you was our senior auditor, Tevi, recently left JPS for a new position elsewhere. So our small team of 3 is now temporarily down to 2. So we're actively recruiting to fill that senior position. In the meantime, we're planning to leverage our co-source partners wherever we can to assist. But again, just wanted to make you all aware of that current vacancy. Just depending on how long it may take to get that filled, there could be an impact to a project down the line. But again, we're gonna utilize our co-source vendors as much as possible to help try and fill that gap in the meantime.
You're going the wrong way, Tim. We're supposed to be adding.
Was that Roger?
I said you're going the wrong way. We're supposed to be adding team members, not taking.
I know.
That's right.
That's the plan for sure.
Well, I want to thank you both and the whole team. This is an incredible amount of work in a relatively short period of time, and there's obviously plenty more to do. But I've been happy with the results of the audits, the good, the bad, and the ugly, and I appreciate everyone there for doing that and for staying on track. So,
yep,
thank you.
Appreciate that. Thank you.
Thank you.
Any other questions?
Nope.
All right, we'll move on. Is Miss Diana Broder there? All I see on my screen are a bunch of yellow triangles on where everybody's faces should be. So I don't know who's doing what. So
I am here, Roger.
Okay, hit it, Diana. Thank you.
You bet. Hi, everybody. This continues the work that you've been doing of removing outdated and no longer needed policies. LD 3700 marketing practices simply states that JPS will comply with state and federal truth in advertising regulations. Legal has reviewed this and decided it's no longer needed. We agree, and we are asking for your approval to archive it.
Has everyone had a chance to see that and to read and understand? And without any questions, I'll ask for a motion to archive LD 3700.
Move for approval.
A motion by DT.
I'll second it, Roger.
And a second by Chairman Dr. Weber. Any questions? Again, we'll vote with the negative. Any votes against this process? Hearing none, we can archive LD 3700, Diana.
Thank you so much.
All right, with that, we've got what I hope is a pretty quick executive session. David, I'll give you and your team a couple minutes to get us secured, and then we'll get cranking here, say about 12:42.
Great, thanks, Roger. We'll be done in just a couple minutes. Thanks.
All right.
I'd like to thank everybody. I'd like to thank all the beautiful triangles here on the left side of my screen for joining us today for this governance committee meeting. It is 1:34, and having no further business, we stand adjourned. Thank you.
All righty. Thanks, Roger.
Thank you all. My triangle's going to wave goodbye, Roger. Thank you.
Adios.
Bye, Winton.